السلام عليكم ورحمة الله وبركاته. أهلا بيكم في المحاضرة التانية اللي هي استكمال المحاضرة الأولى بتاعة الأوفر فيو بتاعة النيورولوجيكال كومبليكيشن بتاع الكوفيد. النهاردة هنتكلم عن البارا انفكتيوس كومبليكيشنز. يعني إيه بارا انفكتيوس؟ يعني complications اللي بتحصل during the viral stage of the disease. ومش شرط إن هي تبقى متسببة أو بسبب الفيروس نفسه، إنما ممكن بكومبليكيشن من الفيروس. يعني مثلا الهايبوكسيا اللي بتحصل دي بارا انفكتيوس كومبليكيشن لو injured the brain، لأنها during the viremic stage during the acute stage of the illness. تفريقا أو تفريقا ليها عن ال post infectious complication. طيب زي ما قلنا إن في بارا انفكتيوس و post infectious أو post acute phase complication. النهارده هنتكلم عن البارا انفكتيوس كومبليكيشن، والمحاضرة اللي بعد كده هتبقى عن البوست انفكتيوس. طيب أول حاجة هنتكلم عليها النهارده الأنوسميا والأجوزيا. دي من الحاجات اللي فيري كومن، يعني سيمتوم في الكوفيد، لدرجة إن خلاص لو واحد عنده برد ومش شامم ده يبقى كوفيد. يعني when a patient have an upper respiratory infection and he cannot smell, we say that this is probably COVID. 40 to 60% of the patient will give you the symptomatology, will complain of smell and taste problem. And if you do a formal test, you'll find that nearly 90% have alteration of smell. So it's becoming a must to do, or must to ask question in patient who you suspect to be COVID. Loss of taste is second طبعا to the anosmia, and the loss of taste can be substantial and lead to weight loss. This is a question. Do you think the cause of anosmia in patients with COVID is infection of the olfactory nerve, infection of the olfactory bulb, or infection of the olfactory mucosa? Contrary to what they thought in the beginning, this is caused by infection of the olfactory mucosa. The COVID, the coronavirus tend to infect the testicular cells, which are support cells, and when these swell, they make pressure on the nerve ending and resulting in anosmia. So it's not a direct effect on the olfactory nerve, it's secondary to olfactory mucosal affection and swelling. This has been proven by studies, and in the beginning there was certain literature that suggested that this is the port of entry of COVID to the CNS, and that there is a retrograde axonal flow of the virus, but this is not proven. And what is proven now is that COVID inflames the mucosa, and the edema of the testicular cells make pressure on the nerve endings. The second most common neurological manifestation is encephalopathy. Encephalopathy in patient with COVID is multifactorial. What does this mean? This means that there are many causes that might cause encephalopathy in these patients. These causes are heterogeneous. There are common causes that you must think about, and there are less common causes. The most common three problems in acute COVID patient that might lead to encephalopathy are the hypoxic-ischemic injuries that might happen to the brain. Why hypoxic? Because this is the main problem of the disease. They affect the lung, and the patient are hypoxic in severe COVID. This might be corrected by oxygen and might be resistant to correction if the patient develops severe pneumonia. So the patient might be hypoxic for a period of time. If you add to this that he is an old man and that his brain is at risk, you might find encephalopathic feature with oxygen saturation that is 85 or 87, or if this is prolonged, it will have later consequences on the brain, exactly like cardiac arrest. In cardiac arrest patients, we have injury to the brain due to the ischemia. The brain cells are deprived from their nutrients and their substrate, the oxygen and the blood, which carries the nutrients. So during this period, the brain is damaged, and then when it returns, already the damage has occurred in the most metabolically active cells, the hippocampus, and when you find a patient encephalopathic and you don't find any other cause, probably this is hypoxic-ischemic in COVID. Of course, sepsis is one of the common causes, and renal affection secondary to the sepsis, or primary kidney affection might cause the encephalopathy, and there are of course overlap between these three main causes, between hypoxic, uremic, and sepsis in relatively a minority of patients, 4%. What are the other causes of delirium? Why a patient with COVID would be delirious? Like any other patient, electrolyte disturbance might cause this delirium. The acid base disturbance, um, the hypoxia, as we said, medication, maybe, maybe withdrawal or medication that has been given in the ICU, antibiotics, nutritional, might be. Patients will be in ICU or in ward, and they are deprived from the vitamins. This needs a little time, but if the patient is predisposed to this, he is alcoholic, he is cachectic, and or elderly, geriatric, vitamin B might be precipitated, vernix encephalopathy might be precipitated during this illness. These are the major cause of delirium. Risk factor: who is more prone to delirium? Of course, age is one of the most common cause of or most common risk for delirium. The older the age, the more prevalent is the delirium. Demented patients, because their cognitive reserve is low. A patient with psychiatric history, prior psychiatric history, patients who are intubated. Of course, the longer the stay in the hospital, the more is the course complicated. And we take delirium as a marker of severity of the disease. Patients who develop delirium during their stay, the prognosis is, of course, poorer than those who do not develop delirium. The discharge home in those who have developed delirium is 25%, but Those without delirium is 66%. As we said, hypoxic-ischemic brain injury in patients who develop ARDS. Um, of course, when there is hypoxia, there is oligodendrocyte cell injury, blood-brain barrier disruption, and microhemorrhage formation. And the location of the injury in this patient are typical of the location of hypoxic ischemic injury post-arrest. The most metabolically active cells that cannot sustain deprivation of their metabolites because they are very active, like the supracortex, hippocampus, Purkinje cell of the cerebellum. A special entity that maybe I will discuss in post-infectious, so I will defer it to the next lecture, the delayed post-hypoxic ischemic leukoencephalopathy. A topic that has been long debated, viral encephalitis by COVID. Is COVID produce like herpes produce viral encephalitis, especially that when in the early reports of anosmia, they said that probably this is one of the ways and the virus gets into the CNS and produce the encephalopathic picture, and there is encephalitis. But repeatedly, CSF has been taken from this patient, and PCR was negative for COVID, except in case reports. There are case reports of viral encephalitis due to COVID. They are not uh, common and they're not rare because they are case reports. I cannot say they are very rare. They are very rare. Okay, but we do not exclude. They are very rare. And this is the case report from Japan. This is medial temporal reminiscent of that of herpetic encephalitis, and this patient was proved to be the PCR in the CSF was positive. Another entity is the acute necrotizing hemorrhagic encephalopathy. It is a special entity that occurs with cytokine storm. It's not strange because the lung also is subjected to to that complication with cytokine storm, and there are hemorrhagic areas. And the imaging, when I reviewed the cases and when I see cases that the stability with image produce their bleeds or micro bleeds or like this, the picture is heterogeneous. The picture is heterogeneous, and I will show you right. The pathophysiology is rather complex, and the more you read, the more you find other mechanisms and how the interleukin 6 activates the CNS and how it affects the CNS. First of all, the interleukin 6 gets past the blood-brain barrier and can activate inside the CNS, the macroglia and macroglia, the oligodendrocytes and other cells, the astrocytes. And when the macroglia is activated, it will in turn activate also other cells. So this is one of the mechanisms that the brain is affected by the cytokine storm, by the interleukin 6 getting through the blood-brain barrier, and also when the macroglia is activated, the immune cells of the CNS, they affect other cells, and they shift the inflammatory response to the CNS. There are other mechanisms by which interleukin 6 can activate directly these cells by the trans pathway, the interleukin 6 soluble receptor that are navigating into the bloodstream gets and directly activate cells. Okay. This is the resume that I just said in the previous slide. How the inflammatory cascades gets into the brain without the virus getting into the brain by the cytokine storm. These are other example of the acute necrotizing hemorrhagic encephalopathy. There is no really response to steroids, but they respond better to plasma exchange and IVIG, immunoglobulin, intravenous immunoglobulin. These are other examples of MRI, example of acute necrotizing hemorrhagic encephalopathy. You see this is a susceptibility weighted image. There is here blooming artifacts denoting hemorrhage. But here the CSF PCR COVID was not performed. This is a 2 months old baby, swab positive, nasopharyngeal swab positive, and COVID CSF negative. You see, this is a sure case of acute necrotizing hemorrhagic encephalopathy. So, after this discussion, how can you describe SARS-CoV-2? Is it neurotropic virus, neuroinvasive virus, or neurovirulent virus? It is a neurovirulent virus. Neurotropic means capable of infecting the nerve cells, neuroinvasive capable of entering the nervous system, and neurovirulent capable of causing disease in the nervous system. The postulated mechanism and the agreed upon mechanism and the proven mechanism is that it is neurovirulent. Type. What the vascular pathology in COVID does not include what? Do you think does not include endotheliitis, vasculitis, perivascular inflammation, or fibrin clots? Yes, it does not include vasculitis. Okay. A stroke in patient with COVID, a big entity, and a sad entity. All types of stroke are seen in patient with COVID. On the venous side, cerebral venous thrombosis. On the arterial side, ischemic stroke with multiple arterial occlusion and even microhemorrhages. The pathophysiology is complex. There is a coagulopathy. Certain patient has antiphospholipid antibody positive, maybe cardiac embolism, and maybe endotheliitis. Of course, the more you have risk factor, vascular risk factor, hypertension, diabetes, and dyslipidemia, smoking, the more you are prone to get strokes during the COVID infection. Myocarditis also is one of the risk factor, acute ARDS. Of course, when the patient has ARDS and the case is severe, he is more liable to have a stroke and also multi-organ impairment. How does stroke happens? There is hyperviscosity during COVID infection because the fibrinogen is increased. So there is hyperviscosity. Contrary to DIC, the fibrinogen is decreased, but in COVID, fibrinogen is increased. There is endothelial injury because the virus gets in on the endothelium with the angiotensin converting enzyme 2 receptor, which is the target for the receptor, and this produces shifts the balance towards thrombose because it decreases the conversion of angiotensin 2 to angiotensin 117, which is anti-inflammatory, so and anti-thrombotic. So it shifts the balance toward angiotensin 2, which is injurious. And thromboinflammation, the hypercoagulable state produced by interleukin 6 upregulation and increased fibrinogen, increased D-dimer, and a whole host of mechanisms by which this gets the hypercoagulable state. So it's not COVID coagulopathy is not DIC. Why not DIC? First of all, the plates are not markedly consumed like in DIC. Coagulation factors are not consumed. Hemorrhagic complications are not common. We see what is common is thrombosis. Is it thrombotic microangiopathy? Severe thrombocytopenia is not present, and intravascular hemolysis also not present. It might be locally in the lung, but it's not. It has not been proven in the brain, for example. Is it HLH, hemophagocytic lymphohistiocytosis? Not the complete criteria of HLH is not there in COVID. There is no splenomegaly, the triglycerides are not increased, and so forth. It's a very challenging virus, and the mechanism by which it produces the coagulation abnormality, we should call it a coavidopathy, a new way this virus is getting into our coagulation system. Does COVID stroke has special characteristic? It occur in young age with no risk factors. It can occur with young age with no risk factor. It has a prevalence for large artery, not necessarily depend upon severity of the illness. Mild and moderate case can get these strokes. And the mean time for the stroke is between is 9 days, between 5 and 23 days. Okay, we shift gear to lower motor neuron, the muscle. The muscle can be affected in COVID as a para-infectious problem. Acute viral myositis occur, can be quite extensive with myalgia and muscle weakness, and and residual even muscle weakness. Sometimes there is rhabdomyolysis. Even dermatomyositis has been described, and paraspinal myositis, also truncal myositis can be. So we reach the end of the lecture. I hope it was clear, and the next lecture will be about the post-infectious complication of coronavirus. أشكركم على حسن الاستماع، وإن شاء الله نراكم في الفيديو المقبل بإذن واحد أحد. السلام عليكم ورحمة الله وبركاته.